All right, well, hello. Thanks so much for having me here today. We're going to talk about the pyretic neonate, or the neonate with a fever, and we're going to talk about some clinical decision-making rules and a cautionary tale. So we'll start with a case. You're working a night shift in your community emergency department. It's single coverage. It's a critical access hospital. There is literally no backup to the point of you are the only physician in the hospital. And two parents bring in their 4-week-old with the dreaded complaint of fever. And you ask all your questions. How did you measure it? How high is it? Did the child have any other symptoms to go with it? What are the I's and O's? What is the medical history? Basically, you're just trying to get out of every resident favorite neonatal sepsis workup. Blood, urine, cerebrospinal fluid, cultures of everything, empiric antibiotics dependent on age, and admit. Kind of a knee-jerk reaction. It's invasive. It is painful, both for the patient, for the parents of the patient, and frankly, for you. It is time consuming, and typically the workup is negative. So in this particular case, the parents tell you they just noted that the child felt warm. They measured a temperature of 101 rectally. No other symptoms were noted. Otherwise, the child is feeding and acting well. You look at the kid looks fantastic, cutest baby ever, well perfused, normal cap refill, flat fontanelle, active, alert little kid. And you have now entered the Thunderdome. You're facing off with a low risk neonate with a fever. And what do? Do you knee jerk just do the whole workup? Just everything and not even think about it? If only there was a clinical decision rule to help guide you. Well, we've actually been using clinical decision rules in this arena since the 90s. And I mean, really, that's as long as most of us can remember. We've been using some sort of combination of the Rochester, Boston, and Philadelphia rules to try and figure out who really doesn't need the workup when it comes to the very, very young who have a fever. And likely, if you've been practicing for a couple of years, you've seen the ages of these workups that get applied. You've seen the age limit kind of go down. So it started with every child under 90 days. And then it was every child before their first set of vaccinations, which is typically at 8 weeks. And then it was down to like 6 weeks. And then people said, do you really need to do this in kids over 28 days old? And then somebody started pushing the envelope over 21 days old. I don't blame you if it's confusing or if you just haven't kept up, but we'll refresh some of that today. What we know is this: the very young have impaired immunity and a much more permeable blood-brain barrier. They're far more susceptible to bacterial and viral infections, and their physical exam is extraordinarily limited, or rather our ability to recognize sick in this population is very limited. And when we miss stuff in this age group, the consequences can be great. The liability is large, and even if you practice in the great state of Texas, as I do, you can probably get sued for missing a serious bacterial illness, or an SBI, in a very young child who came in with a fever that you decided not to work up. So luckily, we have guidance these days. The majority of the US guidance comes from the PECARN research group. Yes, that's right, folks. It's not all head trauma with this group. They do neonatal fevers too. So our objectives today is to understand when to apply our PECARN rule for febrile infants, if that's the name of the rule, and then kind of remember the elements that we use to calculate this rule. And we're going to review a recent external validation study. We're going to discuss this concept of acceptable miss rate and compare it to complication rate of the procedures we do to not miss the infections. And we're going to conclude in the end whether the PECARN febrile infant clinical decision rule is ready for prime time use. So every decision rule is only valuable if you know who you're supposed to apply it to. And so who we apply this PECARN febrile infant rule to are infants 29 to 60 days old. We'll get into that a little bit earlier because that wasn't what the study set out to do. This excludes premature infants who are born before 36 weeks, infants who've had a fever at home for more than 24 hours, anyone with a soft tissue infection on exam, an indwelling device, so any kind of indwelling catheter, etc., a pre-existing condition, and any child that's received antibiotics in the preceding 48 hours to presentation. It also includes infants who are critically ill. And it's not really super well explained what that means, but they are excluded from the study. So to me, that means a child who's intubated, on high oxygen support, pressor medications, or just unstable vital signs. But this might not be the same definition for everyone. And without explanation, this leaves a little wiggle room. Listen, most children in this country are not seen in a pediatric emergency department, and they're not seen by providers who see a large volume of critical pediatric patients. So I think we have a diversity of opinion as to what is critically ill. This is just the clinical decision rule if you look at it on MD Calc. So let's go over what values we use to calculate this, because this is the best thing about this rule. So the values that you use are a UA, an absolute neutrophil count, and a serum procalcitonin. It could not get easier. All right. We love decision-making rules that don't allow us to waffle. These are numbers. There's no waffle or wiggle room. This is easy peasy. So in this sense, this is a very user-friendly clinical decision rule that's very easy to calculate. The stats also look pretty great. The sensitivity is 97.7%, specificity 60%, obviously lower because we want the best sensitivity that we possibly can, so we're not missing any children. In their big giant study where they did internal validation while they formed the rule, really cool study design for another talk at another time, they noted that they had 9.3 rate of SBI, including the typical diagnosis of UTI, bacteremia, and meningitis. They said using their clinical decision rule when applied, they missed 1 case of bacteremia and 2 UTIs and had no bad outcomes. Seems pretty awesome, right? You're barely missing anything, and you certainly missed no meningitis, the dreaded meningitis. The authors in the limitations section, after doing all of that, left us with this. They needed external validation, and until they got that, they didn't want anyone to use the rule in children 28 days and under. And this was because they said of the increased rate of serious bacterial and viral infection in the very low age group. So that's how we get to that 29 to 60 day age application. So let's talk about that external validation. So we're going to fast forward to August of 2020, and we get some external validation, or rather, unfortunately, kind of lack of. So this was a retrospective data set for about a decade from a single large pediatric emergency department in Spain. They also only focused on children with fever without a source. So if you had respiratory symptoms, et cetera, you were excluded. And they had an SBI rate of 20.5. So that is very different than the SBI rate of 9.3 in the PECARN study. Their sensitivity when they applied the clinical decision rule, they said was only 89%. And out of a little over 1,200 patients, this meant 26 pediatric patients were missed, and 5 of them had what they called an invasive bacterial illness, otherwise known as a positive blood culture or a CSF culture, i.e. meningitis. They also noticed that their population was different than the PECARN population in the sense that 50% of patients showed up with less than 6 hours of fever. And they specifically cite this short duration of fever compared to US patients.
Could you try again?
Siri's talking to me. They specifically cite that because they said, you know, the PECARN study allows for a relatively high rate of procalcitonin compared to other similar studies that have been done in the same time era. And they wonder, with such a short duration of fever, is it almost like the body doesn't have time to elevate things like ANC and procalcitonin? And is that why they were missing so many patients? They also brought up this idea of asymptomatic bacteriuria, and we'll kind of leave that there unless somebody wants to talk about it later. So external validation didn't really work out. Well, this kind of resulted in a little bit of a nerd war, I like to call it. So shots were fired. And Velasco said, like, listen, we don't think your clinical decision rule is all that. And the PECARN group came back and they were like, yes, it is, and you're wrong. So the PECARN group came back and said, listen, we obviously have different patient populations. And then they came back and said, do you have enrollment bias? Because we don't believe that anyone is seeing 20% SBI rate. They cited the fact that retrospective data was being compared to a prospective PECARN studies, and that it was a single site versus the 20 sites that collate together to form the PECARN work group. And obviously, you know, these things we know in research often lead to better data. They also have an independent data center to get data from all of those 20 sites, and this helps limit investigator bias. And they said there was no way to do that in the single site study. And they said in the meantime, while Velasco was doing their work, they've performed a secondary validation on another 1,300 patients, again, internal validation. And they saw similar results again. So their clinical decision rule retained a very high sensitivity and no missed meningitis. And they kept, you know, on this because I think that's a serious thing, is no missed meningitis. And they also said that the Velasco study didn't even use the CDR rate. Okay, well, that's not super helpful, right? At this point, the PECARN work group kind of slightly pivots. And again, they settle on this. We're only going to apply this clinical decision rule to 29 and 60 days old. And for simplicity, they said the ANC rate just needs to be 4K or lower, and the PCT needs to be less than 0.5. So they lowered it. Okay, so let's talk about that. What is an acceptable miss rate for this disease process, serious bacterial illness, in this population, you know, very, very young children? Well, for a UTI with no real terrible consequences, maybe it's not so bad. Maybe it's acceptable to miss a couple kids. For bacteremia or meningitis, I would say you need to keep that rate as close to zero as possible. And that's what's really attractive about the internal validation of the PECARN febrile infant rule, because they keep saying they have not missed any meningitis cases, which makes me feel really good. You know, a sensitivity of 97.7% makes me feel pretty good. The confidence interval is a bit wide. You see it goes down to 91.3%, but the no missed cases of meningitis thousands of children later helps me sleep at night. And I hope it does the same for you. This Velasco external validation, it certainly gives me some pause. But the population that they're studying does seem to be different, whether it's because they're incorrect or not. I don't know, but I would say that it definitely seems to be different, and it leaves me wanting some more external validation. What if we compare our acceptable miss rate to the complications that we cause by performing the procedures to rule out SBI? And they're almost too low to count, so they don't really factor in. It's really difficult to impossible to find any statistics on complications of LPs and neonates, and essentially impossible except for case reports for urine catheterization and blood draw complications. Just as an aside, because people always talk about this, there's a 2.7 herniation rate after LP in children with bacterial meningitis. So quite obviously that is not the LP causing herniation, that is a correlation. And I think we can all agree that having bacterial meningitis is really bad for your brain and causes herniation. Certainly, that's a causative factor that's known. The LP is probably not causative, but it is associated because it's happening in the same time frame. There's also a very low risk of spinal hematoma, an infection, and epidermoid tumor. And of course, you think little kids probably have some headaches and back pains, but very hard to study in this patient population because it's very challenging to determine. So back to our baby, this 4-week-old, as long as they're 29 days or older, we can apply the CDR. They have a temp in your ED. Okay, great. You do your urine test, your ANC, your procalcitonin, and you determine that they're all within the normal range. And so you're very low risk for SBI with this kid. You don't have to do an LP, you don't have to start empiric antibiotics, and you don't have to admit. Personally, I have to tell you, with a 4-week-old, I am still at a point where if a baby gives me a funny look, I will very quickly escalate to LP, antibiotics, and admission. I still do full sepsis workups in children older than 28 days, even though I know the vast majority of them will be negative, only because I know that the risk of the procedure is very, very low. And the risk of me missing bacteremia or meningitis is really, really high. So I do think that the CDR helps with benign presentations. Maybe the child you're seeing doesn't even have a fever anymore. Otherwise, they're perfect in every way. They have normal vitals. They have a very reliable outpatient follow-up and great parental support. The other patient that I would be very careful to apply the CDR rule to is the patient with symptoms of short duration. And I do think that this might have been a reason for some of the misses in the Velasco study. So if a patient comes in with symptoms for less than 6 hours, I might either hold them in the emergency department for a repeat blood draw of that procalcitonin ANC, or just be more suspicious about the negative laboratory markers in general. So in general, we know who to apply our PECARN febrile infant rule to. It's low risk, well infants, no risk factors, and a fever. You're going to get your UA, your ANC, and your procalcitonin to calculate it. The external validation didn't really work out the way that we would have loved it to. We have a slight pivot of our PECARN rule. And are you going to use it? I'll leave it up to you. Likely the answer is sometimes, while we all wait for the next external validation. Thank you so much, and I look forward to speaking to you guys again later in the panel.